It's not an easy talking point. This particular hospital, it's the same one, Medical City Dallas, has a high proportion of commercial payers. It does say that it's, the data says that it's losing money on Medicaid, CHIP, and other government sources, as you can see in that middle chart. However, when you consider the loss according to the proportion of the patients they serve, it's not that great. So it's still a loss, it still should be recognized, and we have built that into the break-even metric. But so we like to look at the far right to understand where their losses are relative to the patients they're serving. So that's also an important point as legislators, as you hear from hospitals, well, we're losing 20% in Medicaid. The next question should be, what proportion of Medicaid patients are you covering? Because that helps balance out to have a better understanding of what their losses really are. Or profit. We have seen many hospitals actually in Texas making a profit off Medicaid. And then this is just, what is the national median break even? We hear that question a lot. Texas, in this example, is actually pretty close to the national median. So how is this tool being used? This is not a tool that was developed for patients to understand where to go for care. This was a tool that was developed for policymakers, and increasingly there are employers and health plans that are looking at the tool to understand how they should be negotiating better. Is there a gap between what they're paying and what hospitals are breaking even at? Now, I'll also say this isn't perfect. This isn't magic. It does come from data from hospitals. There is, in academic discussions, disagreement over whether you should be looking at Medicare cost reports or not, because they're not audited, but they are attested to. They are signed off by CFOs from hospitals. We have had meetings with hospital CFOs to walk through their data, and then we say, tell us if it's wrong. It hasn't been wrong yet. It's true they don't like how it's displayed, but it is, from our vantage point, factual and accurate information. So some of the ways that states have been using the tool, yes, it starts a conversation. So being able to have a conversation on cost with a hospital so that there's some information to go from. Informing policy, there are a number of different ways that policymakers are using this. I mentioned earlier that looking at consolidation, competition, are consolidated systems be able to pull more funds in from health plans? By and large, we've seen that they can. And so we actually do also have a model that we created for states to use to prohibit anti-competitive contracting clauses to give health plans a little bit more equity in their negotiations. We also have a model that looks at mergers and acquisitions, allowing the state to have some information before a merger happens. And it's not always a cost metric that you have to consider in mergers and acquisitions. And states would tell you that as well. Oregon is one state that has done phenomenally in this area. They have a program to look at mergers and acquisitions. They do look at cost, but they also look at care, quality, equity, and if that would help the overall community. We also have had states look at pre and post mergers, Medicare expansion to see the effects that had on hospitals. And then as narrowly focused as community benefit, are hospitals investing at the level that states would hope they would be investing at? We do have a metric in our tool that highlights community benefit. It's typically about 1% to 2% of a hospital's revenue. And if we believe in large part that especially nonprofits would probably be paying more in taxes than that. And so to have a conversation about community benefit versus high prices, this can help bridge that too. But so I believe that's the last slide. Happy for these slides to be shared and welcome anybody to go online and look at the tool. It is free to use.
Turned off my thing. Thank you very much. We'll go to Cynthia next.
Is it on? It is. Yeah, okay. Thank you.
Jason, I'm going to hold back on the slides for now. Thank you. Thank thank you for this opportunity to be here today and share with you really how this hospital price transparency came about and why I and others are here. And really, it's about being able to lower the cost of health care and provide the best quality of care at the lowest possible price. And I'm Cynthia Fisher. I'm a former entrepreneur and CEO of a company called Viacord that I founded and started in the business-friendly state of Ohio, in Cincinnati. And I got to live the American dream. And my husband did too. He's an entrepreneur, and I like to joke and say that my career has been in liquid assets. I have been in blood, water, and beer. So I started Viacord 32 years ago, and my husband started Sam Adams Beer, named after our patriot who was one of the founding fathers of our country and started the American Revolution. Where? In a pub. And I think we'd get a lot more done in law and even in our state legislatures if we go back to our roots and go into a pub and share a few beers on both sides of the aisle, and we'd get a lot more done. And it's also good for mental health because beer makes you happy. So it's a lot cheaper than all those drug ads that we watch at night when we watch the nightly news. But let me share with you why I'm here as a former CEO in life sciences and biotech and entrepreneurship. Is the American dream is being eroded by our healthcare system. And I have decided over the past 6 years to dedicate, having been able to raise venture capital, sell my company off of the public market. We went public on NASDAQ. It now exists today, but from the very beginning and still, we created a novel industry to collect cord blood stem cells as an alternative to bone marrow to save lives. And we were able to do it at 1/20th the cost of a bone marrow harvest. And we were able to do it as a for-profit company for the first time in blood that delivered at 1/6 of the cost of the nonprofit hospitals and cancer centers that we competed with in blood banks. And we were the gold standard, and still are to this day, for the transplant community. We did the first transplants in this country for leukemia. We started with leukemia, Fanconi's anemia, genetic disease, and we also did the first sickle cell in St. Jude's back in 1996. But why I'm here today and why I spend my philanthropic effort and my time here and in Washington, D.C. with colleagues like David Balat and Maureen is to basically allow for every American to be able to thrive and work in any job they want, wherever they want, and to live the American dream. And I don't know if I could start a company again today because of the overwhelming costs of our healthcare system. As it is today, we all work at least 1 day a week just to pay for healthcare, and that's moving to 2. 48% of our state budgets as a whole are spent on healthcare. In Massachusetts alone, 68% of the children under the age of 18 are on Medicaid because the families can't afford to keep them in their plan. Why am I here? Well, I'm fortunate because both my husband and I have been successful CEOs, and now I'm working on how do I philanthropically give away my funds that can be most effective. So I'm here because 6 years ago, there was a perfect storm. A former caregiver of my in-laws, since deceased, I just checked up on her 5 years later, found out she had breast cancer, and was facing financial ruin. She was a nurse, she had coverage, and she was facing bankruptcy. I helped her. We waited a year, but also the protocol she was on was killing her. She was being killed by the wrong protocol for breast cancer. I flew her to Boston, got her to go to the University of Cincinnati instead, tried to pay for her housing and living and support her, but then she would not be able to get her Medicaid. So we had to figure out how we could help. Long story short is in the same month, my handyman of 28 years had alligator tears, and this 250-pound man said, I need to borrow $6,000. My wife turned 50. She was told by the doctor she needed a colonoscopy because she reached that ripe age of 50. and the anesthesiologist charges $6,000. And Cynthia, we pay $36,000 for our coverage. She's a florist, I'm a handyman, self-employed, and we have a $6,000 high deductible, which we already paid, but then we got an out-of-network bill for another $6,000. So now that's at $48,000, and between the two of them, they make $110 pre-tax, and they pay after-tax monies for health care. So why do we have this? Because why am I here is because every single one of us has a story. And I bet each one of you, if we all stood up, we'd have a story of being overcharged by the healthcare system. Why? Because when we can't see prices, hospitals and insurance companies can charge whatever they want. And the Affordable Care Act is all grand and great to try to get everybody coverage, but let's say there is a big flaw with the medical loss ratio, that the insurance companies' incentives are perverse in that the payment is up to 15-20% of the top line revenue spent by that employer and by that coverage. So that means only prices are going to go up because of the perverse inverted incentives, not go down. And if I may, the third person who came to me that got me to leave my home and be on the road for these 6 years was a nurse at Mass General who had cancer, who was told to have proton beam therapy, of which Mass General's plan did not pay. And in their own hospital, they set her up with a social worker to start a GoFundMe, and she came to me for $38,000. So she could get her cancer care up there. And she delayed that care until she could raise her own money, of which she spent all of her savings, $18,000 of that, and was looking for me for $38,000 for the balance. Well, shame on Mass General. Don't worry, they ask me to donate every year. They merged with Brigham and Women's. They're the highest cost hospital system in Boston. They are the largest employer now, and both of them have raised nearly $3 billion to build more glass towers. Okay, they are the crystal cathedrals in our cities and in our states. Now let's get this straight. I thought I heard it all until this morning. And I'm going to thank Jason for letting me share his story. But 64% of Americans delay care for fear of financial ruin. And I thought I was motivated enough to come here, but I'm really glad I met Jason, our sound engineer and display. But Jason shared that his brother had asthma. And his brother was so fearful because of experiences of being overcharged that when he had an asthmatic attack, he delayed going to the hospital. And he delayed throughout the day as he got worse until he collapsed. His partner called the ambulance. He went to the hospital. He ended up in the ICU and died. When is enough enough? And thank you, Jason, for sharing that story. But it gets worse. Jason's family got the bills after his brother's death. Not that they were responsible for those bills, and his brother wasn't covered. And so the local, is it Usher Hospital here? Well, they retroactively put him on Medicaid, so Medicaid could pay his bills. Now let's go to the macro level of all this. And Jason, I'm very sorry for your loss. And I'm here because all of us need to channel our inner Sam Adams as a patriot of this country. And I know you came to do the ideal and deliver the ideal, that we get the best quality of care at the lowest possible price so that everybody is fairly treated. But how do we do that? The foundation, and I'm going to go to The Graduate. You remember The Graduate? I mean, most of us are old enough, right? I don't think there's anybody here who hasn't seen The Graduate. But do you remember when the father gives advice to Dustin Hoffman in that movie? Plastics, thank you. All right, well, I'm going to leave you with another word, and that is price transparency. That is the future, transparency, everywhere in healthcare. The more we pull back that curtain, the more we see that David could have gotten an MRI for $300 at a standalone imaging center. And my husband just went to Mass General and it was $4,500 for that same quality of MRI, with a $425 facilities fee and an out-of-network radiology read that we haven't even gotten the bill yet. Now, hello? Who wouldn't want to pay $300? When we see that there is wide price variation, even in the same hospital on the same day as Sutter Hospital in the Wall Street Journal reported, once the hospital price transparency rules came out and we started seeing these prices, we saw that on the same day, the same team in the same hospital, one woman's commercial health insurance plan paid $6,000 all in for her C-section, and another woman's paid $60,000. $60,000, 10 times difference. Why should Maureen and I pay 10 times difference for any procedure from the same hospital on the same day? It's outrage. But once we pull back this curtain, and transparency, again, transparency is the key. But if I may, I'm just going to quickly show you the macro level of effect and why the American dream is so important to all of us. So I'll go to my slides. If you go up to what this means to us as a country, and I'm going to call to your patriot duty because we have to stop the runaway overcharging from both hospitals and insurance companies. If you look at the United States on this map, the United States pays the most. This is old data. This is from 2019. And so it's approaching 18%. We are now at 20% of GDP, gross domestic product, on the left-hand scale. But if you look at Singapore, at 5% of GDP spent on healthcare, and you look at Japan, longer, healthier lives at a much lower cost. And guess what model Steve Forbes, economist, tells us that Singapore uses? It uses the United States model from the 60s and 70s. Okay, next slide, please. Oops. This chart, Dr. Art Laffer, the Laffer curve, this is the Laffer-Fisher curve. We looked at life expectancy, which is the red line, that has drastically decreased, which basically tells us the quality of healthcare has drastically gone down. In fact, this doesn't go to, that only goes to 2020. But in the last 2 years, we went down by a factor of 2. We're now down to 77 years of age. We went down from 79. And the blue line is the cost of the U.S. healthcare. So next, that's tremendous. So we've heard it today that we're approaching $4.5 trillion spend in healthcare as an economy. That's your day a week, my friends. But McKinsey estimates that by 2025, we will be as high as $6 trillion annual spend on healthcare. Now, all of you have the opportunity to stop this and stop this trend. And it is transparency that will get us there. Let's look at the next slide, please. Okay, we see that the government interference has come into the college tuition as well as hospital prices, and I'll go to the next slide where we see the big impact. Because I'm here not only for the American dream, but I am here for the American worker. Because truth be told, it is not the insurers that are the payers. It is all of us. It is the American worker who pays out of their wages for those premiums. That's right, that would otherwise be wages. Whatever is spent on coverage from the employer could alternatively be wages. We talked about that in this morning's session on ERISA law and the employers taking over commercial insurance needs for wage supplementation. But workers also pay for every bit of Medicare and Medicaid out of taxes. In fact, it's so bad that we are seeing protests in New York and New Jersey this past month because 17 unions in New Jersey found increases in their coverage of 20% and the police union 24%. 24% increases. I just came from Florida Committee 100 of the top CEOs in Florida, Florida Power and Light, AT&T, Disney. Many of those employers are seeing double-digit year-over-year increases in their premiums. The only way we get to attack this is through both the hospital price transparency rule and the transparency and coverage rule, which started in July, where every insured plan, whether it's fully covered by in any plan or for the employer, has to be posted online. This is the American revolution, my friend. I go back to my friend Sam Adams. This is the American revolution in healthcare, is transparency. And you all play the role to regulate it. In fact, transparency and coverage rule has high fines. If those prices aren't posted online by the employer plan or the insurer plan, it's $100 per member per month penalty. And it's up to the states to regulate that. In all but 7 states in this country, the other 7 go to HHS Secretary to regulate. Next slide, please. So let's look at states and what they can do. And Maureen's colleague, Marilyn Bartlett, ran the state health plan when they were in a huge deficit, $9 million hole in Montana. And what did she do, the forensic CPA genius? Decided to do the math and look at the prices. She could only get them at the time, it was before these hospital price transparency rules, by actually being able to use the health claims data. And guess what she found? She found that the state had been allowing the insured contract to just do a sweep. So they had no idea about paying a reconciliation of that account per each claim. So the first thing she did is got control of the gosh darn bank account. Do you think you'd give your daughters or sons a sweep account to take right out of your bank whatever they wanted every month? I don't think so, but every employer in every state plan that I know of other than Maryland's blindly lets the insurers pull money out of that account without having any reconciliation. So that's the first thing she did, and then she looked at the health claims data. And then she negotiated based upon the charts that Maureen showed you. She found every single hospital's Medicare cost data, knowing that they each made at least 10 to 20% on the Medicare state government, the government claims. So what she did is she negotiated at 180% of the Medicare rate. That meant they could make a nice profit, but made every one of those hospitals that wanted to participate in her plan to come to the table and make nearly double profit. And guess what happened in 2 years? She saved $121 million for those 30,000 employees. That's huge. That's getting a fair market price that she was able to control by running the numbers. And so, my dear friends here and legislators, I just say this is such an exciting time because it's up to you to implement transparency everywhere. For the first time, we have transparency from the hospitals. I'll go to the next slide. And the pricing files may be ugly, but this is a beautiful file, and thank you, University of Wisconsin. Anybody from Wisconsin here, I love you. This is an Excel file. I can download it. God bless Wisconsin. Thank you. I use this regularly. Okay, so the next slide is our biggest hospital system in the country, which is the Hospital Corporation of America. If we may, Jason, go to the next slide. Okay, this is their hospital price transparency file. Good luck. It has been so gamed and maneuvered to be percentages of abbreviations that no one can figure out, and you can't even find what childbirth is. So when you look at these files, and we looked at 186 of the files of HCA, and none of them were price transparent, complying with the law. In fact, we looked at over 2,000 hospitals in this country in our semi-annual report, and sadly, after 2 years in, our hospital systems, over 6,000 of them, are merely showing 16% compliance like the University of Wisconsin. Only 16%. That's up to Secretary Becerra at HHS to enforce the law. But when he did finally enforce 2 hospitals with over $1 million fines, the good news is those hospitals came in compliance, looked like the University of Wisconsin within 2 weeks. And so those hospitals in Georgia are well served. That said, we're going to a new model now in healthcare, and I would just look to you to say the biggest thing you can do is look at the contracts of every insurance plan with every provider. Those contracts have violating now what's in law. The Consolidated Appropriations Act has made every single insurance broker in healthcare have to show their commissions, indirect, direct, and non-cash, and cash. And we're finding that commissions for insurance brokers for health plans are over 20%. 20% annually. They're not like your real estate broker where you pay 6%, share 3 or 6% based upon which side you're on, and that's one time. It's 20% every year on every piece of every bit of that policy. Think about lowering those costs negotiating at the table. Now, the other thing we're finding is this wide price variation is huge, but we now have the ability to, every employer has to get access to their health claims data. Well, guess what? It's hard. Most employers trying to get that from the BUCA plans, the Blues, the Uniteds, the Cignas, get delayed, they get messy data, and they can't get access to that claims data and make sure they haven't been overcharged. But that's law now. So is transparency and coverage of prices. And we should know Guess where we can go? We can go, when this price transparency is all here, we're going to have tech companies be able to price healthcare just like we price airlines. And when President Carter deregulated the airline industry, my mom was a travel agent and had her own travel agency, but she had retired because we all shop online now for flights, right? That's okay. But listen, what happened? They competed. Prices became transparent. Prices came down. In real dollars today, we pay half of what we paid in 1978. Planes fly safer, less crashes, and hundreds of millions of people are flying. Well, that can happen in healthcare. But the only way we get there is having full system-wide healthcare price transparency. And we have to make sure, because the Consolidated Appropriations Act also requires no gag orders. And contracts with insurers have gag orders still in those contracts, and the law falls on the employers to make sure that they don't do that. Not the insurers, but the insurers are still putting them in. So we need instead a market exchange, where every state market should have every single price by every single health insurer in every single plan and the discounted cash price posted, so that any tech developer can create mobile shopping tools for all of us in all of our plans. And when hospitals and insurance companies have to compete, prices go down, quality goes up. And when I started my Viacord business, we were price transparent, one price, one patient, all patients. Whether you gave birth next to our lab in Cincinnati or you gave birth in Singapore, you had paid the same price. And every insurer paid that same price. And we did it at 1/6 the cost of our competitors. And on top of it, we published every quality collection by every obstetrician and compared it. Guess what happened? Quality went up because they didn't want to be on the bottom of the list. Don't you think childbirth, we should know how many C-sections somebody does, how many maternal deaths that are there, how many inductions and how many are born naturally? Don't you think we should know how many $1 million babies get into NICU? How many get induced week 37, 38? I'm sorry, those babies aren't baked. But hospitals make more money when they do C-sections. So all of that data being public, being transparent everywhere we are, it is only going to give us consumer choice, to drive down costs, and to get better care. And so I end with this to say, what had the Trump administration take off the dust from the shelves of existing laws, 4 of them, but they used to. The Affordable Care Act gave us the right to know all standard charges in healthcare before we get care. HIPAA tells us that we as a patient have the right. HIPAA is not for privacy, my dear friends. It is for portability of our health information. The P is portability in HIPAA. We were to get prices, past, present, and future payment information in a digital file provided portably to every single patient. That hasn't happened yet. But we should certainly know what we paid for insulin last year versus what we're paying this year. And we should have a provenance of all that data because it's our data. So finally, I would say that the other thing is ERISA law. Every employer who's self-insured under the ERISA plan is a fiduciary because that's our wages. And they have been blind to no prices, blindsided by overcharges. And the insurers pay those overcharges. And we make every single one of our employees and workers and anybody who gets coverage, when you go in, they give you an electronic pen now. You don't even get to see what you're signing. They tell you sign in. You don't know you're signing to give away all of your information, let the insurance bill you, even if you're paying cash, which is usually 40% less than the insured plan, and you're paying with a blank check. Because hospitals now are collecting credit cards as well before you go in. If you're in labor, you got to swipe a Visa card, $2,500 if you want to deliver in that room privately. You didn't even know it. You're in labor. This is happening across the country. And then they're charging 16 to 31% interest on those cards. Some hospitals are selling credit cards. Shame on them. Okay, so
Cynthia,
we
I'm
have
sorry.
the opportunity.
We
thank
just
you.
need to wrap up so we can get
We
to
have the
tables.
opportunity to lower the cost of health care, and the employers that got the Affordable Care Act and ERISA law to be used were the ones that basically ran the numbers, just like Maryland did in Montana, Marilyn Bartlett, is they actually saved 30 to 50% by direct contracting with hospitals, by understanding the numbers, by steering. Look at your insurance contracts, anti-steering provisions, anti-audit provisions. We have to get rid of that. The employers that lowered the cost and brought these prices down got rid of all of those handcuffs, and transparency has saved lives, and God willing, this will never happen again to someone like Jason's brother. Save lives and save money, and it's going to take all of us to demand these prices and to demand transparency. And I thank you for all of your efforts and your patriot duties to deliver this. Thank you.
Thank you. And Terrence, thank you for being patient. You're the last one here, so
No
if
problem.
you can bring us to the end.
Sounds great. I'll just wait for my slides and, okay. Hi, everyone. My name is Terry Cunningham. I am the Director of Administrative Simplification Policy with the, is this not, sorry. Okay. Is this better? Sorry. Hi, my name is Terry Cunningham. I'm the Director of Administrative Simplification Policy with the American Hospital Association, and I'm happy to be here to talk about hospital price transparency. So my general plan will be to go through an overview of the federal hospital price transparency, how that law has been implemented, the ways in which hospitals, the ways and degrees to which there is hospital compliance and some of the progress that's been made, and what are some steps that should be taken in the future to ensure that we get to a place where a patient can understand what their costs are before entering into and receiving care. So price transparency rules. In the original legislation, one of the ways in which they specifically said hospital price transparency rules were developed was to provide clear and accessible pricing information online about the items and services that a hospital provides. David covered this, so I won't go too long on it, but the hospital price transparency final rule identified two ways in which the pricing data needed to be displayed on a hospital website. The first was comprehensive machine-readable files. Those had to include gross charges, discounted cash prices, payer-specific negotiated rates, and de-identified minimum and maximum negotiated rates. There also had to be a consumer-friendly website for 300 shoppable services. 70 of those are specified by CMS. The other 230 were based on hospital care volume. So if you give a lot of a particular service, that had to be on your online estimator tool. I will note that these are very different. The comprehensive machine-readable files, I agree with David, they're difficult to understand. They're designed to be consumed by machines. And so I think one of the main reasons with the machine-readable files is that there has been some difficulty in the formatting there. There was not much guidance from CMS on exactly how to format. They just said, put this stuff in a machine-readable file, but there wasn't clear answers to how should I do it? How do I answer certain things with this? So, hospital price transparency rule implementation. So this rule took effect January 1st, 2021. I do not need to remind all of you, but this was right smack dab in the middle of COVID-19. Hospitals were in the midst of changing the entire way they were doing business because they had to figure out how to answer the call and treat all of these influx of patients. This meant taking some of the people who would be revenue cycle folks that have to now figure out, how do I handle all of these waivers and these different telehealth? How do I bill insurers for this? What is this insurer doing with their prior auth policies? Have they relaxed them? How do I reconfigure my system so that I can meet the need of this public health emergency? A lot of staff and resources committed to that at the time in which this rule went live. Additionally, and I touched upon it, there was a lack of clarity on the formatting and some of the other reporting issues with those 5 figures. I'll note that each contract that a hospital enters into with a health insurer is different. All contracts are not the same, and so to try to put them all into the same format is not an easy task. There was a lack of understanding as to how do you deal when you've got services that are bundled in your contract, and some of the specific idiosyncrasies that would be part of a contract. How is this being implemented and reviewed? CMS is conducting compliance reviews. This involves proactive audits of hospital websites and reviews of complaints on CMS's hospital price transparency website. There's a website that you can go, and if there is if a patient is experiencing difficulty receiving the information they need on their website, they can file a complaint. But CMS is also doing prospective audits of hospital websites. How are they enforcing this? They have kind of a three-step process. They issue warnings and notices for a lot of hospitals, and this is, again, your website does not meet what we envision this being the requirements under the law. You need to come into compliance. There's also corrective action plans, and I think these are important because these are specifically when CMS identifies and says, this is how you have to make yours. This is what we think is problematic on your, with your file, and this is how you bring it into compliance. Really, and then the third is, as Cynthia talked about, civil monetary penalties, in which if hospitals do not get their systems into compliance, CMS has the authority to issue civil monetary penalties. There's also an upcoming OIG report that I'll mention, and this is the Office of Inspector General of the Department of Health and Human Services, that is looking at and assessing the current enforcement of these federal regulations to the extent that they're reviewing, decide, are we actually enforcing this appropriately? Do we need to take different steps? So that'll be an important information to come. So what is the hospital compliance in progress? I want to note that the Centers for Medicare and Medicaid Services is the only entity that can deem a hospital compliant or not compliant. This is because in order to determine if a hospital is compliant, it involves a detailed review. These are complex files, as we saw. They're JSON files. It's difficult to understand. Oftentimes they're JSON files, or they can be Excel files, or there's not much, they're complex files. And these are complex contracts that hospitals enter into with their insurers. There's contractual idiosyncrasies that have to be identified, and how do you specifically handle if something is a bundled service, where do you place that into the specific file? Just specific kind of decision trees that hospitals have to go through and figure out how they enter into this. And there's formatting discrepancies. Again, this comes down to there wasn't much guidance as to exactly how am I supposed to format this. So you arrive with some people that have a very pretty Excel spreadsheet, and you have some people with a JSON file that is machine readable, but it might not have been what folks might have wanted. And I think in order to really review and determine if a hospital is compliant, you really need to dig into it. And so CMS is doing that, and it's been a collaborative approach. And one thing I'll point on that CMS needs to be doing this is because there's others who are trying to track whether there's hospitals are compliant, and their estimates are widely divergent. You've got Patient Rights Advocate, I believe Cynthia just said that hospitals are about 16% compliant. A report that came out more recently, that report is from Turquoise Health, which identified it was closer to 2/3 of hospitals are compliant. And then you've got Milliman, which was, again, similar to like a 2/3 that identified hospitals as being compliant. My point in bringing that up is these are all people that are trying to track that are trying to track hospital compliance, and they're arriving at widely divergent numbers. It's because it's complicated. The regulation is complex, and identifying and working through this is a difficult process that CMS is doing in a collaborative manner. And we appreciate that CMS has been collaboratively working with. As of June, they were actively working with over 160 hospitals and health systems to ensure that they are meeting compliance. And in this work, they've released additional resources produced in consultation with hospitals. And again, this is things like voluntary file formats and data dictionaries. These are the types of complexities that were not addressed in the original regulation. And now they've realized, oh, this is going to help hospitals get into compliance. It's really an evolving regulatory framework. So with all that being said, what should be done? What's the future? And I'll turn back to the goal of hospital price transparency. And this is from the CMS website, and it's empowering patients with the necessary information to make informed healthcare decisions. So, today, where can a patient turn for pricing information? Well, they can go to the hospital machine readable files that we've talked about today. They're on the websites. They can go to the hospital cost estimator tools. These are the cost estimators that are supposed to be more patient access and friendly. They can go to the insurer machine readable files. This is the transparency and coverage rule. They can go to the insurer cost estimates on their website. They can go to private tools. When I'm talking about this is Fair Health, things of that nature, which are going to utilize claims history and et cetera, and other available information to analyze and project what your expected cost would be for a particular institution. And then on top of all this, the No Surprises Act that came out recently issued a completely different way of trying to get at prices. There's an advanced explanation of benefits that is in the works. That is being processed and promulgated through regulation by CMS that would allow a patient who wants to know their price for a particular service to request from their healthcare provider and say, I want to know what this would cost for me with my benefit structure with my insurer. So it would basically, the process would take pretty much doing a pre-service claim running it through a payer's adjudication system, and having that spit out, this is what your bottom line cost would be. It's not available now, but it's another thing that is kind of out in the sphere that will be considered. I want to point out that this leaves the patient with 6 different ways, and I'm going to tell you that these might not be consistent. We saw it in David's. Oftentimes, the numbers might not be consistent. What do you do when they're not consistent? 6 different figures, 6 different ways of getting at the numbers slightly differently, each of them. My point is additional legislation and regulation is not the answer here. We don't need another way of reporting this information or another expectation or regulation for a hospital to come into understanding. There's an oversaturation. More data and more reporting mechanisms are not inherently better. We just went through. There's 5 currently available, and truthfully there's probably more, but I highlighted 5 currently available sources of getting this information and a 6th that's on the way. It's also premature to determine that the federal government's the federal program is not working. Truthfully, this is a program that, again, started in the middle of COVID, and hospitals have been, and it came with a little bit of lack of regulatory insight. Hospitals are working to come into compliance. Is it perfect yet? No. There's still some that are not compliant that are working to do so. But I'll point to this quote that came from NCOIL Health, which again is an industry, it's a company that is tracking these numbers and trying to build figures for patient cost access. And they said 24 months ago, many doubted whether or not the price transparency rules would survive the U.S. Court of Appeals. Now we've seen the largest health system and payers, now we've seen most of the largest health systems and payers in the United States publish negotiated prices for all items and services. For a historically slow-moving industry, this feels like Formula One speeds. So I think we take a step back and realize this was a completely new process, and we're still working through it. But we're making progress, and hospitals are coming in compliance. So let's make sure that there's enough time for that to actually take place before we add another regulatory requirement on. Let's make sure we fix this. And so what does need to be done? There needs to be streamlining and identifying the optimal tool usage. It's imperative that the industry creates alignment and makes sense of these varied price estimate and transparency tools. This involves healthcare financial literacy. Patients don't know what resource they should be using and what that resource's figure does and does not mean. We have a huge problem with healthcare financial literacy in this country, but this is another way in which it rears itself, right? Patients are met with all of these options, but how do they use them? How do you know which one is going to be the most appropriate? What figure should you rely on? What's your source of truth with all these different ways you can get cost estimates? Patients need a clear direction as to where to go for a particular type of pricing information, because the differences in reporting estimates that could be created, David highlighted them, right? You've also got, David highlighted them, you've got the advanced explanation of benefits. That's probably going to have, you could have another figure that's different. So if we have 6 things right now that are delivering different numbers, what do we do? What is the patient supposed to believe? You're just going to sow more distrust and lack of understanding as to what's something going to cost. So we as an industry need to figure out what are our price transparency tools, how do we use them, and what is the most appropriate for a patient in a particular situation. With that concludes my presentation. I really appreciate it, and I believe we move on to the Q&A, and I look forward to your guys' questions. Thank you so much.
Thank you all, and now we'll open up the floor to Q&A if anybody has any questions.
Thank you, Madam Chair. I sort of see the fallacy in all this because we see patients. Patients don't really care what it costs. They care what their insurance allowable is. And when you're requiring providers or hospitals to run it through the insurance, the problem is if you're holding the hospital or the provider liable for the reimbursement, and then they run it through the estimator, the insurance company doesn't guarantee that the estimate they give you will be the final payment. So, I mean, how do you, with the Texas law particularly, how do you deal with that disparity in requiring hospitals to abide by the estimate, but not insurance companies?
Pardon me, thank you. Well, if I can address the first thing you said, I appreciate the question. Thank you very much. Patients do care about the price. It's not just the benefits, because when deductibles are $5,000, $6,000, $8,000, and I've seen them as high as $10,000 and $12,000, we're cash patients. The insurance industry has said that 80% of all Americans never hit their deductible. So therefore, we are cash patients. And it's important to know that if there is a CAT scan that is in network at Hospital A versus Hospital B, and there's a disparity that may be in the area of thousands of dollars, I'm going to pick with my pocketbook and go with the one that's more affordable. In Texas, we did have, we codified both the coverage and transparency and the hospital price transparency laws at the state level. But your question was, how do we hold the insurance companies accountable as well?
Well, but as you know, if you file a claim, the patient doesn't pay on the cost that you charge. They pay on the insurance allowable if you have insurance.
That's correct. So that's why it's so important to know what those allowables are. And so if there is an allowed amount, let's just say I've seen a normal vaginal delivery of the variability is anywhere from $6,000 to $56,000. That patient should be able to get that estimate in advance to know what that means. And if there is the ability to look in advance for something that is scheduled, like having a baby, they can talk to their doctor and say, look, well, you're in network at this other facility. Their in-network rate for my insurance is $6,000. I would rather go there.
If I may, I agree with your initial position of patients really want to know what is the allowable as it sits with my insurance. And I think that's why we've seen so much promise, albeit operationalizing hasn't taken place, but there is promise because I think it's getting at the right information when you're talking about the advanced explanation of benefits that are going to be delivered as part of the No Surprises Act. It's not just publishing the charge, it's publishing what is the hospital charge when put through the adjudication of my health insurer, what is the hospital's allowable and expected, what is the insurer's allowable and expected amount going to deliver? I think that's an important thing that I think is more useful than just having a hospital cost or an insurer cost. I think it's extremely important to know, given my specific insurance situation, because everyone's got specific insurer situations. You might have a limit as to how many things you can get that might be flagged. There's a lot of different things than just a steady cost. So I think it's an important thing that we're supportive of and hoping to ensure that it is operationalized in an efficient way. But that would get at kind of the concerns that you have with how do you get at that specific type of information.
May I ask a follow-up? Yeah, and I mean, my other concerns, so say I actually understand how to use, this computer program, which probably most patients don't. And I find that there's going to be a less expensive option, particularly if I'm a cash pay patient. But that person's out of network. So how does that, I guess, Texas has surprise billing, and I guess maybe at some point we'll get the adjudication done federally, but who knows?
Hello? Okay. If I may, the beauty and price transparency system-wide between the hospitals and the insurers is to clearly understand the wide-scale price variation between the charges. So no one of us would tolerate paying $500 for a gallon of milk when the person in front of us in line pays $5. In fact, both the person in front of us in line and we would go to the store manager and ask for the same fair market price. With my Viacort business, one price, one patient, all patients, I knew what my costs were and I knew what I could charge, and I made a great profit at 1/6 the cost of our competition in the nonprofit medical centers. There is no reason why we can't eliminate the many layers of middle players that are capitalizing on a patient's misfortune. In fact, we're told that the average number of entities that handle and charge for their handling between the time of a patient's encounter to the time that bill comes out is 5 separate businesses. Many of them are owned by the hospitals. Okay? So that's just to get your bill. That doesn't count the insurance side. The only way we can really pull back this curtain is when we have every single patient that comes to us with an overcharge, like a Mason Kochel from Colorado in Grand Junction was charged $15,000 for an EpiPen coming out of the hospital, handed one. That was a real charge. He had a $5,000 high deductible plan. Then the insurance negotiated $4,900. But we helped him go online and looked at his negotiated rate, which was $300. And the charge master, the high funny money charge master rate was $600. Yet this poor 20-year-old, for an EpiPen, was being charged $15,000 and negotiated down to $4,900. Both the insurer and the hospital, quote unquote, when he confronted both of them in a letter, the CEO said we had a glitch in our system. How often are Mason Cotchels being charged and overcharged across this? And the only way we can see this is to pull back the curtain. And Terrence, I do object to the findings. We look at it binary. The hospitals either have the data like the University of Wisconsin or in dollars and cents per every pricing field, or it's missing. And you saw in the HCA file, it was blastly missing. Now, HCA will tell you they're compliant because they have a file out there. Turquoise Health, we love them because they're probably one of the best assimilators right now, but their customers are hospitals and insurance companies. They have not yet pulled back the curtain for every employer in this country. So their market is to let everybody else look under everybody else's skirts right now, okay? Let's be real. But Turquoise gives a 5-star rating. So yes, Terrence, 2/3 do have files out there, a third don't. Those thirds should get the $2 million fine each right now by CMS for not even having to file 2 years later. And the 5-star rating is based upon the level of information that's missing.
Cynthia, if I want to, if I may, I reached out to Turquoise, and I asked them, I said, would you consider adding a line of what percentage of hospitals are complying with the law? Robust negotiated rates at 65% may be construed to be compliant by many, and I wanted to make sure that we're communicating what is and what is not happening. And the response from them was, the impact report is focused on price transparency data, and as such, we are not reporting on compliance with the patient estimate tool requirement. They're talking about compliance with their own methodologies. They're not talking about the percentage of compliance compared to what is required in law.
So if I may, you know, the strategy of the thousands and thousands of lobbyists and lawyers are to kill by delay. This is revolutionary. Price transparency is so transformative because it ushers in quality discovery. Because people, all of us just want to know, what are we going to get? And at what price? And the more we have the prices accountable and guaranteed, like the Surgical Center of Oklahoma, Texas Free Market Surgical, those surgeons have only lowered costs for the past 15 years. Why? Because their own insurance rates went down because they guarantee the price. And the actuaries, they said, why do our own liabilities go down? They go, well, we know you hire the best anesthesiologists and the best recovery teams because you stand behind your prices. And we see it time after time that you publish your quality and you publish your infection rate. And these folks are saving so many employers that send in an airplane and a limo service and a hotel room and a 5-star because they can save $50,000 on a knee replacement. And so this can happen everywhere. But when the medical bills match the prices, we all win. And we stop the free annual checkup where one of our employees was asked by the doctor, how are you doing? He goes, well, I'm a little sad. You know, it's been COVID and everybody wears masks and everybody's isolated. But otherwise, I'm doing fine. Pulled aside. Jeremy, you owe $92 out of pocket. Well, why? That was my free visit. Well, the doctor treated you for depression. He said, I don't have depression. He just asked me how I was doing. And it's like COVID. It's sad times that we're all not living our lives. So they upcoded him on his free visit. How often does that happen in revenue cycle optimization? The only way we get at this is we have a guaranteed price that free is free.
Forrest?
Thank you. Thank you. Can you hear me all right? This has been a really fascinating conversation. I really appreciate it. I have to push back a little bit on, you know, patients who only care about what their insurance covers are patients who have insurance. And we make that assumption way too often. And until we separate employment from insurance coverage, that'll be the conversation. But especially because of high deductibles, it really is a cash market. And I'm from Oklahoma. The Surgical Center is a shining example of what is possible. I just have to ask, convince me that we don't need more regulation to see true price transparency that doesn't require the patient to have a master's degree in navigating these complicated systems. I appreciate that it's taking a long time to change systems and that there's been a pandemic. But please, I really do need some more convincing that we don't need more regulation so that people can look at the services like they look at a menu at a restaurant to determine what they can afford. So I'd like some feedback there.
Sure. So I didn't give the entirety of the No Surprises Act, but I will now in terms of the price transparency provisions in the No Surprises Act. I talked about the advanced explanation of benefits, right? There is an additional part of it that's actually live now. It is the good faith estimate for self-pay and uninsured. So if you are a cash patient that is that plans to pay out of pocket rather than have it go through your insurance, you do have the same rights. You can request from your hospital in advance of a service, say, I would like to know what this is going to cost me, specific to me, specific if I was to do it on this date. And you're able to get within 1 day if it's between 3 and 9 days out, and 3 days if it's 10 plus days out. You get the exact figure that you would be expected to cover. It's your good faith estimate. And the regulation, the extent to which that differs from your final bill, if it is more than $400 off from your final bill, you can take that provider through what's called the provider dispute resolution process. And you effectively have the rights to go through an arbitration-like process, or not arbitration, but a mediation-like process where the provider will say, this was my charge, this is why this differed, and this is why it was medically necessary. But it protects patients to ensure that they're not getting these surprise estimates, and it is a way of getting price transparency without having to have a master's degree. It's just go request from your doctor, I'd like to know what my price is, I'm self-pay, I'm cash pay, I don't have insurance, something like that. And you're going to be able to get that specific information. That went live earlier this year. And then there's some other provisions as related. Again, this regulation is starting to roll out, and they're operationalizing a lot of it. But that is something that's out there, and I think that would meet the need that you're talking about. But I agree that the machine-readable files might not be the perfect situation, and there might be a need for, I'm not necessarily trying to sell you that the machine-readable files are perfect, but I think there are, and that's kind of when I got to the streamlining, right? Let's figure out what is the best way for a patient. Let's make it so they don't have to have a master's degree. Let's figure out, hey, you know what? Let's use the No Surprises Act stuff if you want to get your specific information. And let's tell patients that so that they're not overwhelmed by all this different stuff and overwhelmed when they see a binary 0101. Like they don't need to see this machine-readable file stuff if there's an easier and better way. So we as an industry need to streamline and identify the best way rather than introduce additional ways.
Thank you, Madam Chairman. I just want to mention real quickly, I've really enjoyed this, but a Market Watch article that I've been passing out to my fellow legislators for several years from 2019, the U.S. can slash healthcare costs 75% with two fundamental changes and without Medicare for all. The changes are HSAs, the employee keeps what's left of their deductible, and price transparency. And the places that are already doing this are Singapore, Indiana, Whole Foods. The U.S. could save $2.4 trillion, individuals, businesses, et cetera. The problem with health care, and I know you guys know way more than I do, but the problem with health care is it sits outside the realm of the natural law of the free markets. That's the problem with health care. And, if anyone wants this article, it's fascinating. It talks about LASIK and knee replacements and that type. These LASIK's gone down and quality's gone up because it sits inside the realm of the free markets. The natural laws of the free markets. I've really enjoyed this. This has been great. I just wanted to mention that. And if anyone wants this article, it's Wall Street Journal, Market Watch. I'll be glad to share it with you. But thank you all very much.
I would just like to share a quote from the Chairman of Human Services in the House here in Texas, not here in Texas, but in Texas, Chairman James Frank. And we had a select committee a couple of months ago, and he said, transparency without competition just lets you know how much you're getting hosed. And that's absolutely true.
Okay, Robert?
Thank you. And I just wanted to say that the fact that we may have 16% compliance or 66% compliance tells me that we don't know, and either one is too low. And so we may not need more regulation, but we need effective regulation. We surely don't have that. I think we could all agree on that. And I think it would be very valuable for NCOIL to be involved in that. and, look at some model legislation to, it's going to be complex, complicated, but we're out of time, and I just wanted to get that in, that I would like for us to go ahead and confirm that we'll address this if possible in the future.
I agree. Anybody else? No? All right, well, thank you all. Thank you for this. It's been a very stimulating conversation. I appreciate it, and have a good day.
Thank you.